Good morning, everyone. Today, my topic of presentation is fetal genitourinary abnormalities. Uh, Traditionally, the screening of congenital anomalies of kidney and urinary tract we usually do as a part of anomaly scan around 19 to 21 weeks. But CACUT are they are evolving anomalies. Hence, we have to screen for the renal anomalies even in the third trimester also. Hence, later the examination, higher will be the percentage of CACUT detection. Kidneys on ultrasound examination appears as rounded, bright, with anechoic center, which represent renal pelvis in the first trimester. They are optimally visualized in the coronal plane. On second and third trimester, they appear as oval-shaped, less echogenic structures than liver and spleen, with corticomedullary differentiation seen, where the outer cortex will be hyperechoic and inner hypoechoic medulla. This is the uh, ultrasound image in the 13 weeks of gestation, where we can see both the uh, kidneys which are rounded with hypoechoic renal pelvis. This is the 19 weeks of gestation. On the transverse plane, both the fetal kidneys which are present adjacent to the fetal spine. This is on 33 weeks of gestation, where the you can see the callus is small amount of fluid which is present in the renal pelvis. This is the transverse plane showing the same with a small amount of fluid in the renal pelvis. Urinary bladder it should be seen from the 10th week onwards. They appear as anechoic rounded area with echogenic walls. The longitudinal length of urinary bladder should be less than 7 millimeter in the first trimester. Wall thickness should be less than 2 millimeter, and the perivesical arteries or the uncolored Doppler should be visualized to confirm its bladder, not the any anechoic cystic lesion in the uh, fetal pelvis. We have to reassess the bladder if it is not seen. Ureters and urethra they are not usually visible prenatally unless they are diseased. This is the normal urinary bladder which appears as anechoic structure in the renal in the fetal pelvis in the 12th week of gestation. This is the perivesical arteries which is present in the walls of the bladder on color Doppler. Sonographically, the Cackett anomalies they are classified as urinary tract dilatation, pathology of location and number, altered renal echogenicity, bladder pathologies, and disease of the amniotic fluid. This is the algorithm for the urinary tract dilatation. If there is hydronephrosis, you have to look whether ureters are dilated or not. If ureters are not dilated, then it probably due to pelvic-ureteric junction obstruction. If dilated ureters are present, then we have to look whether bladder is dilated or not. If bladder is not dilated, it's probably due to vesico-ureteric obstruction or unilateral uh, vesico-ureteric reflux. If bladder is dilated, we have to look whether dilatation is severe or moderate. If there is moderate dilatation, it could be due to bilateral vesico-ureteric reflux. If it is severely dilated, it could be due to posterior ureteric valsar or atresia. This is the ultrasound grading of the hydronephrosis. Grade 0 is there is no dilatation of the renal pelvis. Grade 1 is mild dilatation of the renal pelvis. Grade 2 is mild dilatation of renal pelvis with few, few callosial dilatation. Grade 3 is renal pelvis dilatation with callosial dilatation with no renal parenchymal thinning. Here there is renal pelvis dilatation, callosial dilatation with thinning of the renal cortex. This is the very subjective classification which is proposed by Society of Fetal Urology and Grading System. But the most objective method for the detection of urinary tract dilatation is the measurement of anteroposterior renal pelvic diameter, which is taken in the intrarenal part of the pelvis on the transverse plane. The cutoff values for APRPD is the uh, between 16 to 27 weeks of gestation, the cutoff is 4 millimeter. If it is more than 4 millimeter, we take it as urinary tract dilatation. If it is more than or equal to 28 weeks of gestation, cutoff is 7 millimeter. If it is more than 7 millimeter, we consider as urinary tract dilatation. This is the ultrasonographic image on the transfer plane showing the proper measurement of the anterior posterior renal pelvic diameter. Around 22 weeks of gestation, on the right kidney is showing 7 millimeter, and on the left kidney is showing 7 millimeter, which is increased, which is more than 4 millimeter. Hence, here we can call it as urinary tract dilatation. Previously, the previously used terms are hydronephrosis, pilactasis, pelviectasis, pelvic ectasis. These terms are obsolete now. We call only the uh, urinary tract dilatation as the single term which is used for the dilatation of the renal pelvis. It affects the 1% to 5% of all pregnancies. We classify urinary tract dilatation as low risk and high risk groups. This is a table representing the features of the low risk and high risk groups. A low risk group between 16 to 27 weeks, if it is between 4 to 7 millimeters of renal pelvis diameter, we consider as low risk. If it is more than 7 millimeter, it's called as uh, high risk features. If uh, if gestation age is more than 28 weeks, if the renal pelvis diameter is 7 to 10 millimeter, it's called low risk. And if it is more than 10 millimeters, it's called high risk. Then, if there is associated features like cholesterol dilatation, renal parenchymal thinness, increased parenchymal echogenicity, or ureters if dilated, if there is bladder is dilated, if the amniotic fluid is abnormal, if there is any features these are present, we consider as high risk group. Follow-up, usually for a low risk, one additional follow-up after 32 weeks is required. In high risk group, we follow up every 4 to 6 weeks. We have to follow up till the delivery. Postnatally, we have to do two additional ultrasound scans after 48 hours and 1 to 6 months later. In the low risk group, in high risk group, we have to consider antibiotic prophylaxis, and ultrasound is done more after 48 weeks up to the 1 month. We have to uh, do the ultrasound screening, and we have to consider the aneuploidy risk modification if indicated, and we have to advise for specialist consultation, nephrology and urology. The ultrasound image showing the low risk group of the urinary tract dilatation, where at around 19 weeks of gestation, the renal pelvis diameter is 15 millimeter, 5 millimeter on the right side and 4.5 millimeter on the left side. This is the 32 weeks of gestation where the right kidney is normal, left there is renal pelvis renal pelvis diameter is more than 7 mm, that's 9 mm. Hence, we consider as low risk group. This is the increased high risk group. At 20 weeks of gestation, it should be less than 7 mm for a low risk group, but it is more than it's 8 mm on the right side, hence it comes under high risk group. At 22 weeks of gestation, we can see there is uh, but there is a pelvic peripheral callosial dilatation. We can see it comes under high risk group, and here we can see there is dilated ureter uh, along with the peripheral callosial dilatation. Hence, it comes under high risk group. And we can see there is increased cortical echogenicity compared to the echogenicity of the liver. There is increased cortical echogenicity, hence it comes under high risk group. Etiology for urinary tract dilatation. It usually, most commonly, it is transient, and it constitutes about 41 to 88%. Ureteropelvic junction obstruction, it constitutes about 10 to 30%. Vesico-ureteric reflux, it constitutes about 10 to 20%. Uretero-vesical junction obstruction, which constitutes about 5 to 10%. Duplex collecting system or ureterocele, which constitute about 5 to 7%. Multicystic dysplastic kidney constitute about 4 to 6%. Lower urinary tract obstruction, which constitute about 1 to 2%. Abnormalities of the location and number, it can be classified as unilateral renal agenesis, bilateral renal agenesis, ectopic kidney, and the fusion anomalies. Unilateral renal agenesis incidence is 1 in 1,300 pregnancies. It is usually associated with bacterial anomalies. V stands for vertebral defects. A stands for anal atresia. C stands for cardiac anomalies. TE stands for tracheoesophageal fistula. R stands for radial and renal defects. L stands for limb defects. On ultrasound, there will be empty renal fossa on the affected side, and there is lying down or sleeping adrenal sign, and AFA will be normal because the contralateral kidney will be normal, and the anomalies in the visualized kidney or the contralateral kidney, we should look for the anomalies. This is the lying down adrenal sign where there is empty renal fossa with longitudinally lying adrenal gland uh, beside the fetal spine. It's called lying down adrenal sign or sleeping adrenal sign. Bilateral renal agenesis, the incidence is 1 in 4,000 pregnancies. It's a lethal condition. It's usually associated with cardiac, cerebral, and skeletal anomalies, and there is syndromic association also. On ultrasound, there is early anhydramnios due to uh, or absence urine production because bilateral kidneys will be affected. Usually seen after the 16 weeks of gestation, and urinary bladder is not seen. Renal fossa will be bilateral renal fossa will be empty. Bilateral sleeping adrenal signs will be present. On colored Doppler shows there is no renal arteries arising from the abdominal aorta. This is the uh, picture showing there is a non-visualization of the bladder during the 1 hour of observation, and second image showing there is bilateral absent empty renal fossa with sleeping adrenal sign. These are the gross image showing the uh, adrenal glands which are flattened. This is the colored approach showing in the below image you can see there is this is the abdominal aorta which is bifurcating into both iliac arteries, and these are the renal arteries which are arising from it. In the above image where there is bilateral renal agenesis, there is absence of bilateral renal arteries. Next is ectopic kidney. Ectopic kidney, the incidence is 1 in 1,000 pregnancies. Uh, Usually, pelvis is the most common location because mainly due to the failure of the ascent of the kidney during the development. You can see there is this is the bladder, and you can see this is the kidney which is present in the fetal pelvis, in the ectopic site. Horseshoe kidney is mainly due to the fusion of both the lower pole of the both the kidneys. They will be fused inferiorly and in front of the aorta. And this is the image showing this is the right kidney and this is the left kidney. There is fusion in the lower pole. It's usually associated with Turner syndrome. Echogenic kidneys. When the kidneys are more echogenic than the liver and spleen after 17 weeks of gestation, it's called hyperechoic kidneys. Causes are mainly classified as non-hereditary, hereditary, and syndromic. Non-hereditary causes are obstructive dysplasias, multicystic kidney disease, nephroblastomas, and renal vein thrombosis, ischemia, aneuploidy, and infections. Hereditary causes are autosomal recessive polycystic kidney disease, autosomal dominant polycystic kidney disease. Syndromic associations mainly Meckel-Gubler syndrome, Beckwith-Whitman syndrome, Bardet-Biedl syndrome. Bardet-Biedl syndrome. This is the ultrasonic image on the transfer section shows bilateral increased echogenic hyperechogenic kidneys because the echogenicity is increased compared to the surrounding liver. Uh, this is the longitudinal section showing the hyperechoic kidneys with multiple cortical cysts. Algorithm for hyperechoic kidneys. We have if there is hyperechoic kidneys on imaging, we have to look for whether we have to look for the size of the kidneys. If the size of the kidneys is reduced, we have to think of obstructive cystic dysplasias. If the size of the kidneys are increased, we have to look whether there is macrocyst or microcyst. If there is macrocyst, we have to think of multicystic kidneys. Microcyst mainly due to polycystic kidneys, and if there is other along with microcyst, if there is other anomalies, we have to think for syndromic causes. Autosomal recessive polycystic kidney disease, the incidence is 1 in 20,000 to 40,000 live births. It's usually lethal condition. It occurs mainly due to the mutation in PHP1 gene. On ultrasound uh, imaging can be normal up to 20 weeks of gestation. Both kidneys will be enlarged with hyperechoic with loss of verticomedullary differentiation. Bladder is usually not visualized due to severe oligohydramnios. Severe oligohydramnios and further causes lethal pulmonary hyperplasia, which is the most common cause for death in this this case. This is the ultrasound imaging. At 30 weeks of gestation, you can see there is both kidneys are enlarged in size with increased echogenicity with loss of corticomedullary differentiation. This is the picture repeating the same features. This is on the coronal scan. Autosomal dominant polycystic kidney disease. The incidence is 1 in 1,000 pregnancies. On ultrasound, there will be moderate increase in size of the kidneys with hyperechoic cortex and hypoechoic medulla. There will be multiple small cortical cysts will be present. Renal pelvis and bladder will be visualized, unlike in the autosomal recessive polycystic kidney disease, where bladder is not visualized. Amniotic fluid will be usually normal or slightly decreased in this disease. This is the ultrasonic sonographic image on the coronal scan. We can see there is bilaterally enlarged kidneys uh, with increased corticomedullary differentiation due to increased echogenicity of the cortex. Multicystic kidney dysplasias. Incidence is 1 in 1,000 to 5,000 live births. It's usually unilateral in 80% of the cases. On ultrasound, there is a bilateral. On ultrasound, the affected kidney will be increased in size. There will be multiple non-communicating macrocysts of variable size will be there. Outline will be irregular in this disease. The contralateral kidney usually have the abnormalities like reflux will be more common in the unaffected contralateral kidneys. This is a unilateral multicystic dysplastic kidney where we can see there is the kidneys are increased in size with the multiple macrocysts which are present in the cortex with increased echogenicity. This is the urinary bladder. This is the image at the 28 weeks of gestation. You can see there is, the cysts are increased in size with increased cortical echogenicity. They do not communicate with each other. This is the rare case where bilateral multicystic kidney disease, which usually occurs in 20% of the cases. On transvaginal image, we can see both the kidneys are enlarged in size with multiple cysts. With there is no renal parenchyma which left. Whole of the kidneys is filled with multiple macrocysts. Meckel-Gubler syndrome is usually associated the features will be there will be occipital encephalocele. In this first image we can see there is ultrasound shows the occipital encephalocele. On the gross image we can see there is uh, occipital encephalocele. This is the kidneys. We can see multiple microcysts which is present in the kidney with increased echogenicity. This is the gross image showing the same, and we can see post-axial polydactyly. There is there is extra this phalange present on the post-axial side. This is the gross image showing the same. Megacystis, which mainly which is also called as the urinary bladder dilated in first trimester. If it is more than 7 millimeter, we consider as a megacystis. Causes will be posterior urethral valves, urethral atresia, urethrosil, cloacal malformation, Brun-Pelly syndrome. This is the megacystis which is seen in the first trimester. Transabdominal scan on sagittal section shows the distended urinary bladder with thick wall. This is the cutoff more than 7 millimeter on first trimester. If there is the dilatation, we consider as megacystis. If the range is between 7 to 15 millimeter, we usually is associated with chromosomal abnormalities, hence karyotyping is advised. If it is more than 15 millimeter, there will be more chances of progressive obstructive uropathy. We have to consider for further follow-up scan will be advised. This is the classification of lower urinary tract obstruction. Uh, Stage 1 is the mild urinary tract obstruction with the only dilatation of the urinary bladder. Stage 2 is severe lower urinary tract obstruction with prenatal findings suggestive of preserved renal function. Third is severe lower urinary tract obstruction with prenatal findings suggestive of abnormal renal outcome. Fourth is lower urinary tract obstruction with intrauterine fetal renal failure. In mainly this amount of amniotic fluid, echogenicity of the fetal kidneys, renal cortical cyst, renal dysplasias, fetal urinary biochemistry. These are the criteria to classify under stage 1, 2, 3, and 4. But the main important part is the fetal intervention. Fetal intervention is not usually indicated in stage 1 of the disease. Stage 2 is indicated to prevent the pulmonary hypoplasia as a complication of oligohydramnios and severe renal impairment. Stage 3 also feature interventions are indicated to prevent pulmonary hyperplasia, but the post-renal outcome it cannot prevent the post-renal disease which occur as a disease process. Fourth stage fetal intervention usually indicated to prevent pulmonary hyperplasia, but not possible to uh, not post-renal renal impairment. Further studies should be are necessary. Fetal interventions in the form of fetal vesicoamniotic shunt is done percutaneously under ultrasound guidance. This is the image showing shunt which is placed between the amniotic fluid and amniotic cavity and the bladder. Next is the fetal cystoscopic laser ablation of posterior urethral valves can be done as a part of fetal intervention. Non-visualization of the fetal bladder mainly occurs due to failure of urine production, which occurs in bilateral severe renal conditions like bilateral renal genesis, bilateral multicystic kidney disease, uh, autosomal recessive polycystic kidney disease, and bilateral renal dysplasias. Or it could be due to severe intrauterine growth restriction or placental insufficiency. Or it could be due to failure to store the urine, which occurs in bladder exstrophy, cloacal exstrophy, cloacal malformation, and bilateral ectopic ureters. This is the algorithm for non-visualized bladder. We have to look in case of non-visualization of the bladder, we have to look for kidneys echogenicity. If the echogenicity of the kidneys are normal, we have to look for amniotic fluid. If the amniotic fluid is reduced with absent or reversed end diastolic flow on umbilical artery Doppler, we have to think of severe fetal growth restriction. If the amniotic fluid is normal, with normal echogenicity, we have to think of genital mass, that's bladder extrophy. If the echogenicity of the kidneys are increased, we have to look for size of the kidneys. If size of the kidneys are decreased with decreased amniotic fluid, we have to think of Porter syndrome. If the size of the kidneys are increased, we have to think of uh, absent amniotic fluid or as autosomal recessive polycystic kidney disease and bilateral multicystic kidney disease. If there is reduced amniotic fluid, we have to think of autosomal dominant polycystic kidney disease. Bladder extrophy, the incidence is 1 in 30,000 live births. On ultrasound, there will be persistent non-visualization of the urinary bladder, small mass present on the lower abdominal wall, and there will be abnormal genitalia. Amniotic fluid will be usually normal. There will be parallel course of the intra-abdominal umbilical arteries, that is K angle. K angle is the angle between the abdominal aorta and the umbilical arteries. It's usually less than 90 degree. That's acute angle. If it is 90 degree or more than 90 degree, you will think of in case of bladder extrophy, there will be 90 degree or more than 90 degree. That's acute angle. Bladder extrophy. This is the image ultrasound image showing there is an irregular mass on the anterior abdominal wall below the umbilical cord. It's the umbilical cord. Below the umbilical cord insertion, there is irregular mass on the anterior abdominal wall. This is the gross image showing the same. Posterior urethral valves, they are the most common cause for lower urinary tract obstruction. It's seen exclusively in the males. On ultrasound image, there will be a dilated bladder with dilatation of the proximal urethra, which usually appear as keyhole, and it's called keyhole sign. And there will be thickening of the bladder wall, which is more than 3 millimeter, and there will be bilateral tortuous hydroureter. This is the keyhole sign where there will be the dilatation of the bladder with the uh, proximal dilatation of the proximal urethra, which appear as a keyhole. And this image we can see there is a dilatation of the ureter, bilateral ureters are dilated. Take home message: bladder must be documented in all trimesters. Genitourinary tract evaluation should be begin in first trimester only. Cagot are the evolving anomalies. Description of renal pelvis, calluses, ureter, and bladder in urinary tract dilatation is a must. Ultrasound findings can prognosticate the renal outcome. Timely antenatal or postnatal therapy can be initiated, which prevents the renal damage and improves the outcome of the affected child.